What is the commonest cause for pancreatitis? This is the most likely slippered gallstone, which is getting stuck in the lower part of the CBD, causing gallstone pancreatitis. Hypertriglyceridemia is rare, but they do present with very severe pancreatitis. Alcohol is rare in pregnancy here, and iatrogenic and other causes are uncommon. So they do present with classical signs of pancreatitis. It is very, very important to do the pancreatic blood test if the pain is persisting and not going away, with, complemented with a early ultrasound. Why is it important? Once the pancreatitis sets in, the systemic inflammatory responses can affect both mother and fetus, and this can be unpredictable. So they should be in a higher center. So early suspicion, recognition, and transfer to the combined care where all the facilities are there are very, very important with rare presentation of pancreatitis. How do you diagnose? Very simple. You do the blood work, labs, and then also check the LFTs and triglycerides, and then do the MRI, ultrasound, and if required, MRI for these patients. We don't do the CT scans for these patients unless there is an abscess or complication. So what you need to know is mild pancreatitis, which has only pancreatic bulky nature, interstitial pancreatitis, no peripancreatic collections. They are safe. They can be treated with IV fluids, nil by mouth, and slow introduction of the diet. Moderate transient organ failure with the local collections. These patients should be in multidisciplinary team areas with tertiary cares, because they can become better or they can go worse. Severe with organ persistent failures will be in the ICU, and their outcomes are not good. Up to 25 to 30% of fetal mortality and less than 5% maternal mortality is common with severe cases. So there will be hypovolemia, ARDS, sepsis in these patients. Preterm labor, fetal demise is common. Early recognition and management that's why is very vital. So most of the time, it is not different from the normal management of the pancreatitis, except if you have rare cause of hypertriglyceridemia, and once you collect the blood, if it looks like this, that means it is hypertriglyceridemia, lipemic serum. These patients do need plasmapheresis. We have done one case here 2.5 years ago. And so most of the time it is a conservative management, ERCP when there is a gallstone pancreatitis, cholecystectomy, planned one, and then these patients should be monitored in the ICU, monitored for complications. Delivery planning should be individualized approach based on the severity. No role for early delivery unless maternal and fetal compromise is there. Multidisciplinary involvement is vital for this management. Recurrence is very common without cholecystectomy, so they should have a cholecystectomy after the delivery. Monitor lipid profile, gallbladder status postpartum. Educate the patient on risk factor, advise the low fat and low meat diet. I was also asked to touch upon the splenomegaly. Currently we have two patients who have, one is with a tropical splenomegaly who is in second trimester, other one has a EHPO, extrahepatic portal hypertension with splenomegaly and mild anemia, thrombocytopenia. She is also second trimester of pregnancy. Both are anemic, and other than the space occupying nature, they can have issues in the third trimester, so careful monitoring by both teams. I will focus on the congestive portal hypertensive case, and other causes are covered by Dr. Ganesh before. So they can have non-specific upper quadrant pain, and if they have a severe splenomegaly, recurrent infections are common. Anemia is part and parcel of this presentation. They can have low white cell counts and thrombocytopenia of various degrees, but that will not increase the risk of bleeding in these patients. Obstetric complications are associated with massive splenomegaly, not with mild or moderate. IUGR can be there. Preterm labor can happen in these patients. One of the main thing is you need to monitor them carefully. Some infections can be serious, and underlying hematological disorders may flare up. Hypercoagulable state is associated with pregnancy, which can worsen portal hypertension. That's why, as Dr. Naveen was also telling, in this group of patients also, we eradicate varices, as hyperemesis might induce portal bleed, and then monitor fetal well-being. So focusing on the portal hypertension, we avoid beta blockers in the first trimester and reintroduce on the second trimester onwards. Few may require platelet transfusions, One of the thing is massive splenomegaly. If there is a prolonged labor or a difficult labor, there is a reported case of splenic rupture. So one should avoid prolonged or difficult labor in patients who have massive splenomegaly. Moderate and mild splenomegaly will be fine. Again, multidisciplinary planning is very, very important. So splenectomy is needed but rare. In usually tropical splenomegaly, if they have pancytopenia, this can be considered when they present very early. Vaccinate before surgery, bleeding rupture, severe anemia, fetal compromise are the issues with this one. So among the gastrointestinal problems, early diagnosed, they are rare. Gastrointestinal complications of organs associated with GI tract are rare, fortunately. Common things are associated with luminal problems like constipation and hyperemesis, which you are all experts in managing. One area we did not cover is the IBD. One message I want to give is all the established regular medications in the IBD are safe during the pregnancy. We have more than 25 years of experience with the biologicals. Azathioprine is safe, no need to stop. And only thing is live vaccines should be avoided in patients who are on biologicals in the first 6 months. Okay, so timely intervention, choosing safer approaches with multidisciplinary teamwork improves both maternal and fetal outcomes. Thank you all.